Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 379 of our pharmacotherapy series, which majors in pain and its management. The first question in this case reads, JPK is a 48-year-old man who presents with low back and leg pain. He has had chronic back pain for several years, which has progressively worsened during the last several months. He reports an aching pain that is localized to his lumbosacral spine with some radiation into his buttocks and hips. He also describes burning pain into his right leg all the way down to his toes. He rates his pain as 7 out of 10 on the numeric pain scale. On good days, his pain is 5 of 10. He recently did some yard work and had an acute exacerbation of his pain. He reports that this felt like 10 out of 10 on the numeric pain scale, and he was in bed for the following 2 days because of pain. He is usually able to do some chores around the house, but activity makes his pain worse. He sleeps poorly, that is only about 4 to 5 hours per night, and he does not go out or socialize very often because he is afraid this will exacerbate his pain. He used to golf and play softball but is not able to participate in these hobbies anymore as a result of pain. He smokes 2 packs of cigarettes daily and drinks about a 6-pack of beer each week. He was previously a plumber, but had to quit his job earlier this year because of health problems. He denies any lower extremity weakness and also denies loss of bowel or bladder control. He has not found anything that really helps his pain except rest and acetaminophen co-formulated with codeine that his sister gave him. His past medical history includes hypertension, hyperlipidemia, depression, and morbid obesity. His current medications are lisinopril for hypertension, simvastatin for hyperlipidemia, carisoprodol, cyclobenzaprine as needed, a baby aspirin, and acetaminophen co-formulated with codeine. He also takes 3 tablets of over-the-counter strength, i.e. 200 mg per tablet, ibuprofen, and 3 tablets of extra strength, i.e. 500 mg per tablet, acetaminophen about 4 times daily with minimal relief of his pain. Upon physical examination, JPK has pain with palpation along his lumbar paraspinal muscles with several trigger points noted and marked tenderness at the level of L4 to L5. His reflexes are intact, and he has full strength in his lower extremities. The remainder of his physical examination is unremarkable except that general deconditioning is noted. There are no laboratory tests or imaging studies available. He reports that his blood pressure is usually around 150 systolic, 80 diastolic, with a pulse around 75 beats per minute. So my question to you is, what are the clinically relevant findings, or absence of findings, for JPK's pain assessment, and how would you characterize his pain? The presentation and assessment of back pain can be very complex given its multifactorial nature. Acute low back problems are defined by the Agency for Healthcare Policy and Research as activity intolerance attributable to lower back or back-related leg symptoms of less than 3 months duration. JPK's acute exacerbation would fit this definition. When JPK has acute exacerbations of his back pain, the numeric pain scale is an accurate assessment tool. His rating of 10 out of 10 indicates severe acute pain. Clinicians should also consider a patient's vital signs, which may be elevated with acute pain. If a patient is unable to communicate, e.g., on a respirator, changes in vital signs may be the only indicator of discomfort. JPK's chronic back pain assessment must rely heavily on the history he provides, because there is minimal objective evidence to base the assessment on, other than his findings on physical examination or imaging studies. He indicated that his chronic pain is about 7 out of 10 on the numeric pain scale. Even though the numeric pain scale has been validated for chronic pain, it is less useful in this setting because it only gives a snapshot of the whole pain picture. A multidimensional tool, such as the Brief Pain Inventory or the McGill Pain Questionnaire, is more useful to assess chronic pain. Physical activities, sleep, diet, and social interactions may be affected by chronic pain. JPK notes that his pain is worse with physical activity. He reports sleeping poorly and has limited physical activity and minimal social interaction. All of these factors contribute to a patient's pain experience and must be considered. Assessment of chronic pain is not only more complex, but is more extensive, because the perception and response to chronic pain is widely variable. Each patient experiences pain in her own way. A psychological assessment is essential to identify comorbidities such as depression or anxiety and any history of abuse, e.g., physical, verbal, or sexual, or previous trauma, as well as to assess a patient's coping ability. It may be helpful to ask JPK about his spirituality and cultural values, because these may offer unique opportunities, or barriers, to any proposed treatment plan. If opioids are being considered, many clinicians endorse the use of a substance abuse screening tool such as the Screener and Opioid Assessment of Patients with Pain Revised, abbreviated as SOPAR, Opioid Risk Tool, abbreviated as ORT, or Diagnosis, Intractability, Risk, Efficacy, abbreviated as DIRE, score. JPK drinks alcohol, smokes tobacco, and has used his sister's acetaminophen co-formulated with codeine. These factors may warrant use of a screening tool to assess his risk for opioid abuse. JPK's chronic pain has been present for several years and has gradually worsened. Based on his history and current physical examination, he appears to have mechanical musculoskeletal pain. He is a former plumber, which involves bending and lifting, which puts him at risk for facet joint arthritis. He describes the aching, localized pain that is typical of arthritis, either in his spine, hip junction, that is sacroiliac joint, or his zygapophyseal, that is facet, joints, which are the most common locations for lumbosacral pain. He demonstrated localized tenderness at the L4 to L5 level. This is most consistent with facet joint disease. He also has tenderness along muscles in his low back, reaching into his buttocks, which is very common, because the body attempts to accommodate structural spine abnormalities. Muscular pain may radiate into the mid-back or into the buttocks, but does not travel below the knees. JPK did not have pain that radiated below the knees. JPK does not have any motor weakness, past experiences, or comorbidities that would indicate a red ag. JPK's physical examination reveals radicular pain in the L5 dermatome, i.e., an area of the skin supplied by nerves from a single spinal root. Unlike muscular pain, radicular pain travels from the spine past the knee into the distal extremities. JPK describes burning and shooting pain that radiates from his spine down his right leg to his toes. These are hallmarks of neuropathic pain. JPK appears to have both musculoskeletal or myofascial and neuropathic pain. This mixed picture is very common with back pain and adds complexity to both diagnosis and treatment plans. My next question to you reads: what comorbidities will affect JPK's presentation and pain assessment? JPK has a concurrent diagnosis of depression, which is quite common in patients with chronic pain. The incidence of depression in chronic pain patients is 2 or 3 times higher than the general population. Depression is often under-recognized in the face of pain as a presenting symptom. Many times healthcare providers investigate for a functional cause of the pain, but overlook the psychosocial aspects of pain. Variables associated with depression in chronic pain are female sex, younger age, lower socioeconomic status, unmarried, Caucasian, and higher pain severity. In fact, because pain severity worsens, depressive symptoms worsen, medical visits become more frequent, and healthcare costs increase. The relative deficiency of norepinephrine and serotonin that occur with depression makes the pain-blocking function of the descending pain pathway less effective. As a result, JPK may feel more pain physiologically and may also have a greater emotional response to his pain and other stressor. His depression may be contributing to his sleep disturbance and his diminished social interactions. Untreated depression may be detected with a multidimensional pain assessment tool. If identified and treated, his pain may improve concurrently with his depression. Other psychiatric comorbidities that commonly occur with chronic pain include anxiety, personality disorders, and substance abuse. JPK also has a diagnosis of hypertension. Although this will not directly contribute to his pain, any acute exacerbations may cause an increase in his pulse and blood pressure. Increases in blood pressure are associated with an increased incidence of stroke. The presence of hypertension is also a factor when developing a treatment plan. He is currently taking ibuprofen for pain, and non-steroidal anti-inflammatory drugs are known to cause fluid retention, compromise renal function, and diminish the benefits of antihypertensives, such as JPK's lisinopril. Corticosteroids, which may be used during an interventional pain procedure, may also increase blood pressure. The next question in this case reads: how can current low back pain treatment guidelines be applied to JPK's pharmacologic regimen? Acetaminophen is considered first-line therapy for low back pain. JPK has been using acetaminophen up to 6,000 mg daily, which exceeds the recommended maximum daily dose. He has also been using some acetaminophen co-formulated with codeine that he obtained from his sister. JPK is at risk for liver toxicity from high doses of acetaminophen. Additionally, he has not found the acetaminophen to be helpful, so it should be stopped. JPK is also taking ibuprofen, which is recommended as second-line therapy. He is taking 2,400 mg daily without benefit. His pain relief is unlikely to improve with a dose increase, but he may benefit from rotation to another non-steroidal anti-inflammatory drug with a different chemical structure. Naproxen is an inexpensive agent that is also available over the counter. He does not demonstrate any muscle spasm, so a muscle relaxant is not indicated, nor is it recommended for chronic back pain. He has radicular pain, so a trial of gabapentin may be helpful. He has been using the codeine-containing product and notes that this has been helpful. However, opioids are not recommended for long-term management and have not shown substantial benefit with long-term use. He should be encouraged to reduce or discontinue use of the opioid. Chang and colleagues recommend a trial of tricyclic antidepressants if non-steroidal anti-inflammatory drugs and acetaminophen have failed. This may also help his chronic insomnia, but the doses used for analgesia, typically less than 100 mg per day, may not be high enough to have true antidepressant effects. Selective serotonin reuptake inhibitors, abbreviated as SSRIs, may be used to treat depression, but have very little independent analgesic effects. However, if his depression improves, we would expect to see a proportional improvement in his pain. Because selective serotonin reuptake inhibitors are better tolerated than tricyclic antidepressants, and tricyclic antidepressants have not demonstrated improvement in function in the long term, JP should have a trial of a generic selective serotonin reuptake inhibitor such as citalopram. Serotonin and norepinephrine reuptake inhibitors may also be an effective and well-tolerated option that would treat both his depression and pain. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 380.